Internet is unstable though, so I'm able to.
Please start.
Yeah, this is regarding the presentation on fetal well-being and fetal assessment. 1 minute. So my objectives are to give some introduction and components of what are the components of prenatal diagnosis, what is the assessment of how to assess the fetal well-being. Babies does not develop merely in the terms of somatic growth. They develop holistically and undergoes a very rapid brain development during the whole pregnancy, and this continues up to 3 years of age. That is the reason positive parenting before the birth will build up the neural connections that are strengthening the baby's brain. Baby in utero experiences world through touch, which is the initial sensation developed by 8 weeks of gestational age. Even an extremely preterm baby has this ability to perceive all the senses and have an organized responses. Because of this knowledge, this knowledge has driven to develop supportive care in neonatal intensive care units. This nurturing framework should help that every baby gets the best start in life. This is the concept of philosophical start to physiological health. So how to do a prenatal diagnosis and fetal well-being? It will be discussed in four stages. First is gestational age assessment, later prenatal diagnosis for aneuploidies, and what is the fetal size and growth rate abnormalities and its effect on the baby, and how to assess the fetal well-being during the labor, antenatally and natally. Then coming to the gestational age, why we need to know the gestational age? Because to accurately time the gestational age is important for any chorionic villus sampling and amniocentesis, and also to assess the prognosis and plan the neonatal care when the preterm delivery is inevitable. So this is also to avoid iatrogenic interventions, because when the wrong dates are there, there are likelihood of interventions which are not needed and they may cause the damage to the baby. Then how we do? There are two methods. One is ultrasound and second is clinical method. Clinical method is not an accurate method. It is done by what is the first fetal movement and what is the first heart sound heard and what is the suprapubic to fundus height measurement. This gives the gestational age measurement, but this is not very accurate. Ultrasound, we call it as a biometry, is used before 9 weeks. We see the crown rump length, and after 9 weeks and beyond 14 weeks, we see head circumference and femur length measurements. And addition to these measurements, we also measure a biperal diameter or abdominal girth and the length of the long bones, which also gives more accuracy in the gestational age assessment. But this accuracy decreases when the gestational age is increasing. Then coming to the prenatal diagnosis for aneuploidies, there are two types. One is screening tests and second is diagnostic tests. Diagnostic tests are invasive. That is the reason screening tests are very important to decide which patient requires these invasive tests. These screening tests are again first trimester, second trimester and combined tests. In the first trimester, in addition to taking into account of the maternal age, we do the serum levels of pregnancy associated plasma protein, which is estimated at around 11 to 13 weeks of pregnancy, and free beta human chorionic gonadotrophin BHCG and nuchal translucency. These three serum screening tests along with the maternal age gives almost 90 to 94% of accuracy in detecting the aneuploidies, especially trisomy 21. There are other conditions which also shows increase in PA-PPA, which are like hypertension, preeclampsias or preterm labor or fetal growth restrictions and extra. And coming to the second trimester screening, This is not actually very sensitive. If first trimester screening is done and the patient is not in high risk, then there is no need to do a second trimester screening test. This second trimester screening test includes quadruple panel, that is quad test, which includes 4 parameters. One is maternal serum alpha fetoprotein and HCG levels, unconjugated estriol, inhibin A. There are combined first and second trimester screenings are required for aneuploidy when there is suspicion of high risk pregnancies. So this combined first and the second trimester are again 2 types. One is integrated screening, that is first we do the first trimester screening, then followed by second trimester screening. In the sequential screening, there is a stepwise sequential screening, that is first we do the first trimester and then later we do the second trimester. In the contingent approach, we do the first trimester screening. When any high risk pregnancies are diagnosed, then we do the next second trimester screening. This is the way we do the screening test and this accuracy. First trimester screening usually 90% detects the trisomy 21% and quad scan is 81%. If both are combined, 96% is the accuracy rate. And coming to the imaging techniques, what are the imaging techniques we use to detect the fetal abnormalities? There are mid-trimester TIFA scan. This is targeted imaging for fetal anomalies. And this is very important and it is usually done around 18 to 22 weeks of gestational age. In this mid-trimester TIFA scan, usually all organic anomalies, brain anomalies can be detected, renal anomalies. And this mid-trimester TIFA scan is complemented by seeing other soft markers in the ultrasound. These soft markers are like ventriculomegaly, thickened nuchal fold, anossified nasal bone, all these things are there. But in due course of time, these soft markers may disappear or may remain same. If suppose a mid-trimester TIFA scan is positive and maternal screens are positive, and these soft markers will have more validity in detecting the abnormal fetus. And now this recently magnetic resonance imaging is also coming for the fetal diagnosis of fetal anomalies, but it is not routinely used. And the second imaging technique is fetal echocardiogram. In the fetal echocardiogram, we do that basic cardiac echocardiographic examination where we will see any cardiac anomalies and outer tract view and or three vessel and trachea view. These are the 3 views we do in the fetal echocardiographic imaging to detect the cardiac anomalies. And then what are the indications for 2D echo when we suspect any congenital heart diseases in the fetus or mother is having any metabolic disorders like diabetes, phenylketonuria, systemic lupus erythematosus, or maternal exposure to any alcohol or any cardiac teratogenic medication is given to the mother. And coming to the last screening test, that is cell-free fetal DNA in the maternal blood. It is usually not routinely recommended. It is recommended only when the mother is more than 35 years of age with a risk of aneuploidy or any history of previous births with aneuploidy, and mother is carrier of balanced translocations or positive traditional screening test is present. Then only we offer cell-free fetal DNA estimation in the maternal blood. This is non-invasive technique. And coming to the diagnostic tests, these are invasive tests. Invasive tests, that is the reason we need to know the indications for these tests. When there is an increased risk of fetal aneuploidy because of a positive screening test and abnormal ultrasound findings, or there is any obstetric history of previous fetus or child affected by aneuploidy, or there is an increased risk for a known genetic or biochemical diseases in the fetus, there is a family history or maternal transmissible infectious diseases, or on in certain circumstances on request by the mother. And then coming to the individual tests, usually this chorionic villus sampling is done around 13 plus or minus 6 weeks, 6 days. This is a diagnostic analysis. It includes fluorescence hybridization technique, karyotyping, microarray and molecular testing, and genetic counseling, genetic sequencing depending upon individual need of the patient. What are the complications? If there is a pregnancy loss risk of 0.5 to 1%, if this chorionic villus sampling is done below 10 weeks of gestation, it is associated with fetal limb defects or oromandibular malformations. And coming to the amniocentesis, it is usually done around 10 to 14 weeks of gestation. And usually it is used for assessing the enzymatic or biochemical or genetic or microbiological studies, for microbiological studies. What are the enzymatic and biochemical analysis usually we do? When there is a increased alpha fetoprotein and along with ACH increase, it indicates neural tube defects. And LS ratio is used to identify the lung maturity, and sometimes increased bilirubin levels are indicative of RHD isoimmunization, which is not now routinely not used. And coming to the genetic analysis on amniocentetic fluid, which contains the desquamated fetal cells, we do the FISH technique. This FISH technique is usually can be done at the interface level to identify the aneuploidies, and metaphase level where we can identify deletions and duplications or translocations. When coming to the chromosomal microarray analysis, it is usually detecting microdeletions and duplications, whereas PCR detects when the gene sequence of producing a particular disease is likely to present is known before doing the test. Then DNA sequencing like whole genome sequencing or whole exome sequencing are used, but they are not routinely used. Next generation sequencing are all used, but they are used only for a specific diagnosis. And then coming to the diagnostic tests, percutaneous umbilical cord sampling. This is the third test which we usually do. This is usually done in the second trimester to term. And this is useful for both diagnostic and therapeutic purposes. It is usually used for hematological or immunological abnormal to detect the immunological and hematological abnormalities in the baby. And then also it provides access to the treatment if at all the child requires in utero treatment. And then complications, 1 to 2% fetal loss is there, and 5% of the patients will go into preterm deliveries. And then last is pre-implantation genetic diagnosis, which is called PGD. Usually it is useful for a wide range of autosomal recessive and dominant and X-linked molecular diagnosis. For all these tests, genetic counseling to all patients is a must, and it should be done before screening or diagnostic tests before you plan, genetic counseling is a must to the mother. And then coming to the third aspect, this is fetal size and growth rate abnormalities. There are two types of growth abnormalities. One is growth restriction, second is macrosomia. Usually macrosomia is why? Because it is usually associated with obstructed labor and all. And this fetal growth restriction is again classified into early onset and late onset. And this is because of either placental insufficiency or maybe because of fetal in nature, which are chromosomal abnormalities or congenital malformations or any congenital infections. This is this fetal growth restriction before 24 weeks. This should be detected before 24 weeks, or when the structural anomalies are associated. It is complemented with soft markers. When a fetal growth restriction is also associated with soft markers, we have to be very careful in assessing the fetus for the development of, for the presence of any aneuploidy. And these are the differences between early fetal growth and late fetal growth differences. Early growth is congenital in nature, and it is there is a compromised growth is present, and physiologically child adopts it into the hypoxic environment of the mother. But in the late FGR, usually they are more prone for hypoxic injuries. There is a high mortality rate if the fetal growth is less than third centile, according to the Porto study. This is a prospective observational trial to optimize pediatric health trial in intrauterine growth restrictions. And then macrosomia gives a risk of shoulder dystocia and traumatic injury. Usually it is associated with maternal diabetes, postpartum pregnancies, and genetic fetal overgrowth syndromes. And then how it is diagnosed, usually by ultrasound examination or clinically by doing the Leopold maneuvers. And then coming to the assessment, fetal well-being assessment is done in antepartum and intrapartum assessments. In the usually it starts from 32 weeks. For assessment of fetal well-being, the fetus should be mature enough. That is the reason only it is applicable after 32 weeks of gestational age for high risk pregnancies like diabetes, hypertension, all these kind of pregnancies. If the mother develops a new risk during the pregnancy or during the delivery period, that is like a decreased fetal movements or any vaginal bleeding. So what are the antepartum tests and what are the intrapartum tests? Antepartum tests are fetal movement monitoring. The mother will monitor the fetal movements. Usually baby sleeps and wakes up. Cycle is 30 to 45 minutes. So mother is asked to count the fetal movements for a period of 2 hours, and 10 or more fetal movements within 10 to 2 hours is indicative of fetal well-being. If the fetal movements are not enough, then it is an indication to further assess. Then non-stress test. The non-stress test and contractions stress test. Non-stress test is estimating the fetal cardiac movements when the baby is inside the uterus, and contraction stress test is fetal cardiac monitoring along with the contraction of the uterus. And then if suppose any non-stress and contraction stress tests are positive, then we go for biophysical profile tests. And then third is then Doppler ultrasonography also will give some information about the fetal well-being. So this is the interpretation of NST and atypical NST. We have to see what is the baseline heart rate and how it is variable from the baseline. Are there any atypical features or abnormal NSTs? When the child is having any variable decelerations more than 60 or second late deceleration, there is an urgent action is required in terms of termination of premature delivery of the baby. Then coming to the intrapartum assessment, usually fetal heart rate monitoring when the uterus is under contraction, we call it as cardiotopography. And what are the parameters we see in that? Baseline heart rate and what is the variability from the baseline, and how accelerations are recorded, and what is the deceleration, whether early, late, and variable decelerations. So this is the interpretation. Baseline usually 110 to 160 is the normal rate, and baseline variability of 5 to 25 is also reassuring. If suppose if the variability is increasing less than 5 for more than 30 to 50 minutes, and this is a non-reassuring cardiotopography. And if it is abnormal, the abnormality is the heart rate either below 100 or above 180. Whenever there is a non-stress test are positive, we have to apply some digital stimulation to the fetal scalp to see any change in the heart rate. If there is no change in the heart rate with a digital fetal skull stimulation, this is an emergency. So we have to take a proper decision making in the delivery of the baby. And also we can take the help of fetal blood sampling and this fetal blood sampling to see what is the pH of the fetal blood sample to know the degree of the hypoxia. So maternal, what are the contraindications? Usually maternal to fetal infection, if the risk of maternal to fetal infection is there, or if the child is having, the fetus is having any bleeding disorders, which is contraindication. To conclude, the prenatal screening for aneuploidy must be offered after appropriate counseling to all the pregnant women, and fetal crown rump length measured in the first trimester is the most accurate estimate of the gestational age. First, second trimester and integrated screening, serum screening tests have increased sensitivity to detect the aneuploidy. Prenatal cell-free DNA screening is a non-invasive prenatal test only recommended for a high-risk group of patients. And ultrasound screening for anomalies is a non-invasive and cost-effective method, even it is available in resource-limited settings. And diagnosis of aneuploidy can be confirmed by chorionic villus sampling, which is an invasive test. And amniocentesis usually performed at 6 to 20 weeks of gestational age for genetic and biochemical microbiological studies. Fetal growth restriction may be due to placental insufficiency or innate fetal causes. Early onset FGR is associated with severe placental insufficiency and risk for eclampsia. And late onset fetal growth restriction is common and is associated with the risk of intrapartum fetal distress and hypoxic changes. And advanced in fetal well-being assessment have significantly improved the management of high-risk pregnancies. So fetal well-being in the antenatal period can be measured by umbilical artery Doppler, biophysical profile, and non-stress test, and in the intrapartum period by fetal heart rate monitoring and fetal blood sampling. This is my presentation. Thank you so much for giving me this opportunity. I was thinking it is in 27th of this month. So I prepared within one day actually. Thank you. If any questions, because there are some chart is seen, but I am unable to read what is there written in that chart box.
Oh, that's great, Dr. Jhancy. Here I am Dr. Anita, moderator for this session. There is a question in the chat regarding the fetal movement perception. So how fetal movement monitoring should be utilized for assessment of fetal well-being?
In this fetal movement, actually the fetus is sleeping in the utero for every 35 to 45 minutes, it wakes up. So mother is asked to count the fetal movements for 2 hours. And then suppose if the fetal movements are like 10 or above, this is called as a good thing. If it is less than 20, then we have to think about intervene.
So there are two methods. In one method, in 12 hours time, mother is supposed to count the number of fetal movements during the daytime, and that should be more than 10 for adequate. In another way, it could be done like this, that for the 3 main meals, like breakfast, lunch, and dinner, after that, mother to lie in the left lateral position and count the numbers, and that should also be around 10. So that is the 2 methods. So these 2 methods are generally told to the pregnant ladies, mostly in the 3rd trimester, to assess the fetal well-being. So that is one. I would congratulate you for the wonderful presentation, and it was very comprehensive and included so many things. But a few things are left. So one thing is that, like in case of growth restriction, so it is assessment of fetal weight and fetal growth on the ultrasound method. So are you aware of fetal charts? How obstetrician do that measurement? How do they say that this fetus is not growing well, this is going into IUGR or something?
Actually, I don't have any idea.
Okay, it's fine. It's fine. I'm just putting the questions for everyone. So
Yeah.
the answer for this is like there are two charts mostly. They are called as Hadlock's and Williams charts. So
Yeah.
there is inbuilt software in the machines of obstetrics,
Okay.
obstetrics ultrasound, and mostly they serially put the measurement like abdominal circumference and biparietal diameter and other things, fetal weight, and that gives a beautiful plot of the fetal growth. So by
Yeah.
that, the fetal the way we chart the neonatal growth postnatally, in the similar way, fetal growth is also measured on the fetal growth charts as centile. So these are Hadlock and Williams chart, which are
Okay.
mostly utilized in obstetrics.
Yeah.
Another question I would like to throw would be regarding fetal echo. So what is your take on the fetal echo? I hope it
Um,
was not mentioned.
Yeah, yes, actually fetal echo is usually done for any to detect any cardiac anomalies.
Yes.
If suppose basic cardiac echo may not pick up all the cardiac anomalies. That is the reason they use two other methods like outlet view method, outlet track view method, and three vessel trachea view. Usually,
That I would say that's wonderful, Dr. Jhancy. You could come out with the fetal echo views and you enumerated that. So that's great. The fetal vessel, three vessel view, and the trachea view, and the outlet flows view. So basically, if there is a sibling, there are certain criteria for the fetal echo, that who should undergo the fetal echoes.
yeah,
And number one mark, there would be obviously the family history of previous
yes,
sibling being affected, or some genetic disorders in which there is significant risk of cardiac anomalies.
yeah. There
Apart
are
from
two
that,
indications: fetal indications and maternal indications.
yes,
Actually,
yes, exactly.
yes.
So there are first trimester marker also for the fetal, abnormal prediction of a congenital heart disease. What are those?
This single, there is soft markers in ultrasound. I don't understand that question. Please.
In the first trimester ultrasound, the TR jet and the ductus venosus flow are supposed to be measured
Yes,
along
yes.
with the NT.
Yeah.
So nuchal translucency as such is a good thing, that it indicates if it is above 95th centile,
Our
it will
ductus
indicate.
venosus flow and also hypoplastic nasal bone is also taken into consideration.
Yes, that's part of the anti-NB scan.
Yes,
So
yes.
that is one of the marker for the significant risk of the congenital heart disease. And over and above, the TIFA is one more thing where the things are assessed. But traditionally, TIFA is supposed to be done at 16 to 20 weeks. But for the good evaluation of brain and heart, you need to do detailed scan at 22 to 24 weeks. For the
Okay.
purpose of heart, it should be a bit later. So that is the problem
Yeah.
with your indication for the termination in case of. So that's a tricky things that should be taken care.
Yeah.
So
Okay.
that was one. And what are your views regarding the fetal monitoring in RHI immunization? You told about the Dopplers, but what is specific about that?
In Doppler, actually, middle cerebral artery Doppler is done. In that,
Yes.
yeah, actually, that if suppose if the risk of fetal growth restriction or anemia are there, and like RHI, immunization or parvovirus, there is an increased flow in cerebral vessels will be seen.
The traditionally what was done, that amniotic fluid bilirubin assessment was used to done very long back, but
Yeah,
these days with the advent of good Dopplers, the middle cerebral artery flow, in
yeah,
any case of fetal anemia, it is not only RH. So RH is mostly determined by the fetal anemia in form of low hemoglobin. So whatever the reason could be of fetal anemia, the middle cerebral artery peak
peak
flow velocity,
velocity, yeah,
peak
peak
to flow
velocity,
velocity
yeah,
should not be more than 1.5 multiples of median. So there are gestation age specific charts on which according to the MOM, it is decided that this baby is anemic or this fetus is anemic or not, and in
Yeah.
that way, the take for intrauterine transfusion is done in case of fetal anemia. The cause could be RH or PARVO or any other thing. So those are the things which are also a part of fetal assessment. We discussed so many hi-fi things apart from the clohalty, but being in our country, we should also know that what are the 5 important investigation which are supposed to be done when the mother get registered for the pregnancy. So what are those 5 tests which are supposed to be advised?
When pregnant, when
A mother is getting booked, that stage in antenatal case. So what would be the 5 things would you like to tell that she should get it done immediately?
blood, this regarding the fetal well-being, usually we do blood.
That this would be done in any case, in even in the district hospital setup, it has to be advised.
Yeah, usually they do the blood grouping and
Yeah.
blood glucose estimation,
Hemoglobin,
percentage, hemoglobin, and then ultrasound, basic ultrasound.
No, not ultrasound. Hemoglobin, blood group, and blood sugar, and viral
Viral
HIV, and
uh,
VDRL. These are the 5 things which are supposed to be done.
yes.
Minimum 5 things, and apart from that, you can do anything.
Yeah.
Then I would also like to ask, what is the minimum number of visit for a lady to be called as a properly booked in case of antenatal?
At least 3 visits should be present.
It is 4 according to WHO. So not recently, it has changed a long time back. We also have been taught like this, that it should be 3, but
3.
it should
Now okay.
it should be 4 as per WHO.
Because now I completely doing only teaching. That's why I'm not aware of these things.
Yeah. So that should be 4, and apart and each trimester should have 1 visit. It should
Yes.
not be like this that their mother just get registered at 28 weeks and she had 4 visits.
Yes,
So in that
each trimester 1 visit should be present, and before delivery, I think 1.5 visit.
Okay. So do you have any idea about what should be the weight gain during pregnancy? Ideal weight gain during pregnancy?
Usually, total 8 to 9 kilos should be present.
Yeah, that is a good average value to remember. But if it is being asked for someone in exam, that answer should come like this: that it depends on the mother's body mass index.
Yeah, both body mass index is more important. Yeah.
So according to BMI, different BMI category has different weight gain. In fact, it is said that a mother who is obese should lose weight during pregnancy and morbid obesity kind of thing. So according to the BMI criteria, the weight gain should be different, and in twin gestation also it should be different.
Okay.
And one more thing is that the value of serum markers are not very much standardized in case of multiple gestation. So that is a one trick, that if someone is having a multiple gestation, then all these serum markers become tricky to get that in the practice.
Yeah.
Or to get concluded. And to end with, I would say that the presentation would have been more interactive if you could have put some NST tracing.
Yeah.
Along with that, if someone I don't know if any of you have seen the result of this first trimester serum screen or second trimester serum screen. How does it look like? How to interpret that? Mostly they have a bar, and that lies in the risk of high risk or low risk kind of graph is there. So how to interpret that, we all should know. In fact, I would say in the neonatology, the perinatology is something which is important, and often the pregnant mother can come to you
Yes.
with those report, and we should not express a blank look with those kind of
Yeah. Actually, I thought this presentation is on 27th. Yesterday only I saw that. Actually, I wanted to keep more case scenarios in this presentation. So because of this time, I couldn't do it.
Yeah,
I will do
that's
it
fine.
next time, definitely.
So there is a question in chat that is, what is the role of PAPE in fetal growth restriction?
In fetal growth restriction, this PAPI levels will be decreased actually. This is a placenta. This is the hormone secreted from the placenta. If there is a fetal growth restriction because of placental insufficiency, usually we see decreased levels. Am I
Yes.
correct? Yeah.
Yeah, that's fine. So that's all from my side for the to make it more informative and what could have been more discussed. I
Yeah,
would encourage it would be encouraged if the participants have some more questions, or they want to put some facts with this presentation.
Yeah, actually, I'm unable to see the chat box. It is blankly shown. Some questions are there, but somehow there. It is not visible to me. So, if
It's
suppose
fine.
if anyone if anyone can ask, it is I will be
It's fine. It's fine. I'm able to, and I will put if anything is there. Mostly the things are discussed, and that's fine.
Thank you so much, Dr. Anita.
Thank you. Your take anything from your side, Nathan? Am I audible, Nathan? Are you there?
Yes, ma'am.
So, any more thing to do?
No, no, ma'am. Let us conclude the session.
Okay. Thank you.
Thank you so
everyone.
much. Thank you, Dr. Nitin, Dr. Anita. Thank you so much.
Thank you, everyone, for joining. Thank you.
Thank you.
Thank you, ma'am.